Hello everyone, today we are going to discuss cord prolapse management, and in AMC they are asking a very simple questions regarding cord prolapse. So let's start that. Okay, to answer all the cord prolapse questions recalls, we have to know the management, that how we can manage, how can we give the first aid, when we will do the emergency C-section, and when we will do the vaginal delivery. Okay, so how to okay, let's start. Okay, first of all, we have to recognize prolapse umbilical cord visible protruding from vagina, cord palpable on vaginal examination, abnormal fetal heart rate on auscultation. Then what we have to do? Call for help. To relieve pressure on the cord manually. How to relieve the pressure? Manually elevate the presenting part. Position woman knee chest position or left lateral position with pillow placed under left hip and head down if possible. Suggest bladder filling if a delay expediting birth is anticipated. Apply dry pad to try to keep the cord inside the vagina. Consider tocolysis with, for example, with subcutaneous terbutaline. Consider clinical circumstances, environment, and urgency. Okay, birth. Assess and assist birth by most appropriate means. Urgency of birth is dependent on fetal heart rate, gestational age. If vaginal spontaneous assisted birth, okay, we have to call that number. Then we can also do the cesarean section, depends upon the presentation of the female, depends upon the heart rate, depends upon the dilatation, cervix dilatation, okay, stage of the labor basically. Prepare for urgent birth, emergency transfer to hospital if in a community setting. Secure IV, assess, take bloods, continuously monitor fetal heart rate, consider clinical circumstances, environment, and urgency. Okay, so post birth, okay, that is not important. Okay, so the most important thing in this cord prolapse topic is that if patient comes to you in second stage of labor and the patient is definitely she is fully dilated, then we have to do the we just expedite the birth, we just speed up the birth process. We will do the instrumental delivery, okay. But if the patient is 9 centimeter dilated, 8 centimeter dilated, then we have to deliver the baby within 30 minutes, okay. It's an emergency, we have to be speed up the process of birth, okay. That is the mainstay of the treatment, right? So I have one more chart I will show you, and then we will solve the recall questions. Okay. Okay. Cord prolapse, recognize cord visible are called cord prolapse suspected. Note time. Cord pulsating and cord not pulsating. Activate local emergency procedures. State clearly to arriving team cord prolapse. Whether possible, team should include senior obstetric doctors, midwives, neonatal teams, and pediatric team as well. Okay, that is very important part. First stage of labor, second stage of labor. Aim for immediate birth through cesarean section. Remember that if the patient is fully dilated 10 centimeter, then it's the second stage of the labor and the patient is fully dilated, we will speed up the process, which will speed up the vaginal delivery, okay. Like we can do the instrumental delivery or anything just to speed up the birth. We will give oxygen, IV access, continue CTG until birth, cease oxytocin infusion if progress, okay. Reduce risk of cord compression until birth, place women in deep knee chest position or place woman on her left side with her head down, elevate the foot of the pad. Manual elevation of the presenting part of the cord. Minimize handling of the cord. Consider tocolysis with terbutaline. Remember that. Consider bladder filling. If cord prolapse outside the vagina, gently place in vagina or cover with the pad soaked in warm saline. Second stage of liver, if presenting part is at the as at below the spine, aim for immediate vaginal birth. Prepare for instrumental birth if appropriate trained doctor present. If there is no doctor trained instrumental birth available, encourage women to push vigorously to facilitate spontaneous birth. If immediate vaginal birth is feasible, prepare for birth through cesarean section. That is the most important thing. Okay, then definitely we have to arrange, if we refer the patient to the hospital, then we need a neonatal resuscitation team, um, uh, what do you call, gynecologist as well, right? So that is the most important part. Okay, so this is essay guideline. Through these guidelines, I just make us very concise notes where we can understand it easily. It depends upon you that you want to read from essay guidelines or from that notes. Okay, so just quickly go through that. The most important thing is, okay, if the patient is fully dilated 10 centimeter, we will do the we will speed up the vaginal birth. We will do the we will advise the female to push the baby. And then the other thing which we can do is that we will do the instrumental delivery. Okay, if the fetus is below the ischial spine or above the ischial spine, we will do, and the patient is fully dilated, then we will do the instrumental delivery. But okay, if the patient is in first stage of not in the second stage, it's in the first stage, then definitely we will plan for emergency C-section. But yeah, first we have to save the patient until that time period. We will do, it's in 30 minutes to 1 hour emergency protocol as per SA guidelines. So until that time period, we will save the baby. So what we're gonna do it, we will do the knee chest position. We will put the patient in knee chest position, left lateral. And then the other thing is that, so if okay, we cannot, and we will elevate the presenting part of the fetus, that we will put our hand, and then we will elevate the head of the fetus. When we will elevate the head of the fetus, then definitely there is less pressure on the cord, right? So we cannot do that elevation for a longer period of time with hand. So the another alternative is that we will use the bladder technique. Okay, in we will filling the bladder catheter to, and just we fill the bladder catheter with 500 to 750 ml saline, and then we elevate the presenting part with that catheter. Okay, so we will read the questions as well, recalls, all the recalls questions. So nothing to do anything extra. Okay, cord prolapse, descent of cord through cervix alongside a cold are passed overt, presenting part with rupture membrane. Cord between presenting part and cervix with or without intact membrane. What is cord presentation is something different. Cord prolapse is something different. Risk factors for poor outcomes: prematurity, congenital anomalies, birth asphyxia, delays in diagnosis, especially in the home birth. So knee chest position, most important thing, and stage of the labor. If the patient is in second stage, we will do the, what we will do, we will immediately deliver the baby vaginal birth, right? And if patient is not fully dilated 9 centimeter, and in the scenario if you see anything like patient is not fully dilated, so then in that case we will do the caesarean section immediately within 30 minutes. Until that time period we have to give oxygen to female. Okay, risk factors table. Risk factors generally multiparity, low birth weight, preterm labor, congenital anomalies, prepresentation. Prepresentation is very important. Transverse oblique, unstable lie. Second wind, polyhydramnios. Remember that polyhydramnios. Procedure related, artificial rupture of membrane with high presenting part. Very important. Remember that. Routine ultrasound, not sensitive, specific, not recommended except in research. Okay, selective screening may be considered in breech at term considering vaginal birth. Cord presentation diagnosis, how we can detect that: weekly transvaginal ultrasound in breech beyond 36 weeks reduce cord prolapse incidence. Okay, prevention. Women with transverse oblique unstable lie after 37 weeks should be considered for inpatient care. Preterm rupture of membrane with non-cephalic presentation, inpatient care recommended. Avoid rupture of membrane if presenting part is high and mobile. If artificial rupture of membrane is necessary, ensure immediate cesarean section arrangements are available. Avoid upward pressure during vaginal examination with rupture membranes. If cord fell below the presenting part, avoid rupture. Cesarean section usually indicated. Suspicion and diagnosis. Exclude cord prolapse at every vaginal examination in labor. Remember that after spontaneous rupture of membrane. So rupturing of membranes, artificially rupturing of membranes are spontaneous. We have to think about that. That cord prolapse will might be the complication. Okay. Suspect prolapse with abnormal fetal heart rate, bradycardia. Okay. Okay, if you do the artificial rupture of membrane, then according to the assay guidelines, what we're gonna do is we have to before rupturing of membranes, we will do the CTG, and after rupturing of membranes, we will do CTG, and we will also do the speculum examination of vagina just to make sure that the patient is fine, there is no cord prolapse and everything. Routine speculum digital exam is if suspected. And very important thing, during after spontaneous rupture of membrane, if you do the CTG and if you find that variable prolonged decelerations, then okay, it's cord prolapse, right? So remember that suspected cord prolapse in CTG shows variable prolonged deceleration. They have been asking this question multiple times in recalls. Okay, so bradycardia, we will see bradycardia, variable prolonged deceleration. Perform speculum and digital exam if suspected. Routine vaginal exam not indicated after spontaneous rupture of membrane if it heart rate normal and no risk factor. If there is no risk factor, then we will not do. But in polyhydramnios, arterial rupture of membranes, we have to think about that. Call for immediate resistance. Prepare for birth in theatre. Do not attempt manual replacement of cord above presenting part. Not recommended at all. Minimize handling of the exposed cord, because if you try to handling the cord, we will get the vasospasm. Okay, so it's another complication. So minimize. So that's why we have not to touch the cord again and again. Alleviate presenting part manually or through bladder filling. As I told you, maternal position, knee chest or left lateral, head down below under hip. Tocolysis considered if persistent fetal heart rate abnormalities and delay expected terbutaline, or always avoid delay indefinite birth. Okay, in this scenario, if you see that okay, the two options, patient is on syntocinon and now patient is diagnosed with cord prolapse. What you gonna do it? Taper off syntocinon. In the option, if you will get taper off syntocinon, so remember that never taper off in cord prolapse. We have to stop the syntocinon, not taper off. Okay, and the other thing is that in that always the safest option is knee chest position. Always the safest option is chest position. Okay, cesarean section recommended unless vaginal birth is imminent. Category 1 cesarean section aim to birth within 30 minutes if abnormal fetal heart rate. Category 2 cesarean section possible if fetal heart rate normal but continue monitoring essential. Okay, vaginal birth of course is possible at fully dilatation if rapid and safe. If prolapse diagnosed at home, advise knee chest face down until transfer. During ambulance transfer, exaggerated seems what you call maneuver, left lateral pillow under hip. We also call that exaggerated seams during ambulance transfers. Transfer all cases to consultant-led unit unless imminent vaginal birth, presenting part elevation, manually a bladder insertion, minimal handling of exposed cord. Okay, so these are the important things. That things are not important at all. They just keep repeating the simple thing. Okay, how we diagnose this cord prolapse? Definitely through clinical examination. Suspect if sudden fetal bradycardia and fetal deceleration after rupture of membranes. Confirm vaginal exam through palpable cord. If cord is palpable, definitely you come to know. Always do vaginal examination if abnormal CTG after rupture of membrane. Remember that. Management, immediate actions, do not delay. Call for help. Continue CTG. Prepare for urgent delivery. Manual elevation of the presenting part, most important step. Maternal position. Manual elevation, maternal position. Knee chest, left lateral with head down, bladder filling. Stop stop oxytocin, stop, not taper. Don't be confused. In exam they will give the taper off and they will choose the taper off. No, stop oxytocin, consider tocolysis if delayed. But the safest option in exam is that knee chest position. Okay, mode of delivery we already discussed, right? Fully dilated, instrumental vaginal delivery. Decision to deliver interval less than 30 minutes. It's all from essay guidelines, guys. Definitive treatment, cord prolapse, it's an obstetric emergency. First step, elevate the presenting part. Definitive treatment, delivery. Most cases, emergency cesarean section. Do vaginal examination if CTG abnormal after rupture of membrane. Okay? And another word they use, Trendelenburg position. Nietzsche's Trendelenburg position. It's very difficult to pronounce this word. Okay, so remember that in exam sometimes they just play with the words. Okay, stop oxytocin and tocolysis. Call for help. First step, manual elevation of the presenting part, knee, chest and Trendelenburg position. Fill the bladder, continue CTG, immediate delivery. Okay, within 30 minutes. So these are the different guidelines. So I already explained everything. So yeah, let's solve the questions, recall questions quickly. Okay, so these are the recall questions. A 39-week pregnant woman in labor is found to be 9 centimeter dilated, or in some scenarios they mention 10 centimeters. So management is completely changed. A prolapse cord is noted in the vagina. What is the most appropriate next step in the management? Replace the cord. Definitely, we will never replace the cord. Macro-upper maneuver we will use in shoulder dystocia. Immediate cesarean section. Maternal pushing, instruct a mother to push. Okay, so here the trick is that if it's the patient is 9 centimeter dilated, then we will do the immediate cesarean section. But if the patient is on 10 centimeter, then the answer is maternal pushing, instruct the mother to push. If the cervix is fully dilated and nearly so and the presenting part is low, the fastest way to relieve pressure on the cord is immediate vaginal delivery through maternal effort and instrumental assistance. 9 centimeter management is completely changed. Emergency cesarean section. If it's 10 centimeter, then we will advise to do the maternal pushing. Okay, this is understood. Okay, so next question is in male. Cord prolapse occurs after rupture membrane. The cord is visible below the presenting part, and the contractions have just started. Option knee to chest position or fill up the bladder. So definitely the most important knee to chest position. Positioning the mother in knee chest or head down position uses gravity to shift the fetus away from the cervix and the prolapse cord. Okay. By time measures. That is very good thing actually. In August they are asking cord prolapse is diagnosed and the theatre is currently occupied. What you will do that? Inhale salbutamol, IV terbutaline. So remember that terbutaline it's a tocolytic agent, and salbutamol too, it's also a tocolytic agent, but they mention inhaled salbutamol. So tocolysis we will do subcutaneous, or we can also do IV. Okay, subcutaneous or IV terbutaline. Tocolysis with IV terbutaline can be used as temporising the measures to reduce uterine contraction and pressure on the cord while waiting for emergency cesarean section. So we don't know the other options, but remember that we will give tocolysis with IV terbutaline or IV salbutamol. Remember that. Okay. Cord prolapse is categorized as is class. Okay. Next question is that indication for emergency cesarean section. In March they have been asking. Cord prolapse is classified as category 1 cesarean section indication, meaning there is an immediate life-threatening compromise to the fetus, asphyxia, and delivery should ideally be occur within 30 minutes, as we already discussed, right? Within 30, it's a category 1 cesarean section indication. Okay, CTG pattern. Cord complications in February they are asking, including prolapse. A true note tightening during labor classically manifests as variable deceleration. Remember, variable deceleration and prolonged deceleration, fetal bradycardia due to imminent or sustained cord compression. So in CTG pattern, what we are seeing, they are asking about what you can see in CTG. In CTG, we will see variable deceleration and prolonged deceleration. Remember that variable prolong, variable prolong, variable prolong. Recall notes suggest cord prolapse, and the next one is in May. Recall notes suggest cord prolapse is commonly associated with malpresentation, breach or transfer lie, a high presenting part at a time of membrane rupture or polyhydramnios. Okay, so in the question they might ask about the risk factors. So remember that risk factor you have to memorize: small presentation, high presenting part, rupture of membranes and polyhydramnios. Okay. Okay, fully dilated 10 centimeter head low, instruct the mother to push and just to speed up the birth, right? Cervix 9 centimeter, urge to push, maternal pushing or instrumental delivering. Now, 9 centimeter will do the 9 centimeter we will do the emergency C-section. Okay. Cervix not fully dilated, knee chest position and emergency C-section. Waiting for theater, occupied IV turbital to reduce the cord compression. Positioning priorities, knee to chest at Trendelenburg position. Okay, these are the next recalls. Following an emergency cesarean section, a true note in the umbilical cord is identified. Okay. Which of the following fetal heart pattern on the CTG we can see that variable or prolonged deceleration. Okay, we can see variable or prolonged deceleration, acceleration, early deceleration. Acceleration is a good thing on CTG, right? Acceleration is a good thing. On acceleration is a good thing. Early deceleration, it's also sometimes benign finding. And sinusoidal pattern is an emergency pattern. The patient is the fetus is hypoxic. Okay, but related to node we always get these findings: variable or prolonged deceleration. A true umbilical cord node can tighten during labor, causing acute fetal hypoxia. This typically manifests a variable deceleration due to cord compression or prolonged deceleration. If the fetal heart rate does not recover, an emergency C-section is required to prevent the stillbirth. Cord entanglement recall. A picture is provided showing cord entanglement or a single tight node. What will CTG finding shows? Deceleration. Okay, I don't know how they give us the picture. In ultrasound, we have the what you call U sign, which shows us the cord entanglement. You can see on YouTube video regarding like how we can see on scan cord entanglement. Okay. I don't know how they show the picture. True umbilical cord knot tightens during labor, causing hypoxia, variable and prolonged deceleration. Remember that they have been asking. Cord entanglement identifies via picture or ultrasound deceleration. We can see the deceleration. Okay, just give me a second. I need to check that. Okay. Okay. So next recall is membrane have ruptured and umbilical cord is visible below the presenting part. Replace the cord definitely no. Fill the bladder, yes we can. Put the patient in knee chest position, that is the most important thing. Okay, if the knee chest is not an option, then the other option is Trendelenburg position. Head down, left bladder is used to move the fetus away from the cord through gravity. Okay, in addition to positioning, what secondary action can be taken? Okay, manually push the presenting part up and fill the bladder with 500 ml of saline to keep fetal head elevated of the cord. Now in the March recall, they have been asking, okay, in addition to positioning, what secondary action you can done? So what we can do after position the woman, we will manually push the presenting part up, right, and fill the bladder with 500 ml saline to keep the fetal head elevated and off the cord. So in these vessels, I don't think so they use any trick. It's very simple. Definitely delivery route is determined whether the cervix is fully dilated. Okay, that is very important point, right? As I told you multiple times. A 39-week gestation patient has a cord prolapse into the vagina. The cervix is 9 centimeter dilated. Station plus 2. Station plus 2. Plus 2 station is always good station, right? And vitals are stable. And then 9 centimeter. Okay, as I told you in previous recall, it was they mentioned that speed up the birth, vaginal birth. No, in 9 centimeter it takes time, and we have only 30 minutes. How can we do the in 9 centimeter? We can do those vaginal delivery. We cannot do nothing. We cannot do anything until it's fully dilated. So immediate cesarean section. Cervix fully dilated, 10 centimeter here, and the heart rate is dropped. Correct action is the instructor mother to push. Okay, so just repetition. Okay, cord prolapse is diagnosed, head is 2 centimeter above the ischial spine and the cervix is 8 centimeter dilated. The theater is chronically busy. What you will do that? Inflate the bladder, subcutaneous turbinolene, arrive salvin breaching, tocolysis to stop contraction, reduce cord protection, inflate the bladder. So indefinitely, first of all, what we're gonna do it, we have to elevate the fetal head. That is the most important step, right? So in this step, first we will do inflate the bladder. Okay, inflate the bladder definitely, and then the second step we will do subcutaneous terbutaline or IV salbutamol bridging tocolysis to stop contraction and reduce cord pressure. But first we will do the inflate the bladder. Correct answer for this specific stem, right? Cord prolapse is diagnosed and the head is 2 centimeter above the ischial spine and the cervix is 8 centimeter dilated. The theater is busy. So which option which we need to choose? That inflate the bladder. That is the protocol. Okay. First of all, as what we learned that in the chart, just remember that first inflate the bladder, then we have to do the terbutaline. First step is already done, right? So next recall is a true knot is identified in the cord following an emergency section for fetal rest. Which CTG pattern? We already did this, right? So it's just repetition of the same recalls. So we already read this. Let's go back to this chart. Okay. Oxygen IVSS continuous CTG until birth, sees oxytocin infusion if in progress. Place movement in deep knee chest position. Place movement on left side with head elevation. Manually elevate the presenting part of the cord. Okay. Minimize handling of the cord. Consider tocolysis. Consider bladder filling. Okay. Tocolysis. See, for tocolysis, it's not a initial step. First, we have to place the woman in knee chest position. Then woman on his left side with her head down, elevate the foot of the head of the bed, right? Manually elevate the presenting part and then we will do the tocolysis, right? Knee chest position first step, then place woman on her left side with her head down, elevate the foot of the bed, right? Manually elevate the presenting part of the cord. Minimize handling of the cord. Consider tocolysis. Consider bladder filling. If cord prolapse outside the vagina, gently place in vagina or cover with pad soaked in warm saline. Okay, so the thing is, according to this table, first of all, any manually elevate the presenting part of the cord, minimize handling of the cord, consider tocolysis. Okay, as per this chart, first we give the tocolysis and then consider bladder filling, right? Okay. Okay, as per this chart, first we have to give the tocolysis and then consider bladder filling, right? Okay, I have another chart. Let's read that chart. Just a bit confusing. Okay, I have one chart. It's in SA Health Guideline. These are the positions, okay? Deep knee chest position and left side head down position, okay? Okay, let's read that point. What they are manually elevating the presenting part is reasonable if there is immediate access to theater. If clinician should insert sterile glove fingers into vagina to elevate the presenting part of the cord, avoid excessive handling, cover the woman and expedite the birth. IV intravenous tocolysis, terbutaline salbutamol may be effective adjuvant treatment while preparing for theatre or if a delay is experienced. In case where there is a delay in transfer to theatre for cesarean section hepatic, consider elevation of presenting part through rapid instillation of sodium chloride to the bladder. Means bladder filling. Okay. Ensure woman bladder is empty before any birth attempt. If if a delay in in transfer to theater is expected and pulsating cord is prolapsed outside the vagina, the cord may be replaced in the vagina and pad soaked with the saline. There is insufficient data to prove the benefits of either method. Any of the methods to cause the bladder filling position should not be used if they will delay the birth of the baby. Immediate resuscitation of neonate. Okay, now manually elevate the presenting part is reasonable if there is an immediate access to the theater. Okay, if there is no immediate access to the theater, then we will do the tocolysis first. Okay, I will work on that question. You can also work and then choose the option wisely, please. Follow the guidelines, follow the guideline. That is the most important thing. Okay, so I think the answer is actually tocolysis. Okay, let's go back to that question. Sorry, that is another. Okay, so that question is actually confused me. Hmm. Okay, so this is the question. Okay, it's diagnosed the head is 2 centimeter above the ischial spine and the cervix is 8 centimeter dilated. The theater is currently busy. Temporising option: inflate the bladder, subcutaneous terbutaline or IV salbutamol, bridging tocolysis, stop contraction, and reduce cord pressure. Patient is on 8 centimeter. The theater is currently busy. Okay, you will check and then I will check too and I will let you know in my another video. Okay, thank you. Bye bye.